Welcome to the Living Chronic Special Series, Military, Medicine, and the Mission Left Behind. In this powerful series, we're taking a hard, unflinching look at the cracks in the systems meant to care for those who serve. We'll examine the deep cuts to the military health system and how they're impacting service members, retirees, and military families. We'll talk about the VA, what's working, what's not, and the looming threats of cuts and privatization. We'll tackle the tough topics others often avoid: suicide, PTSD, gaps in care, and the devastating ways veterans and families are being left behind. You'll hear real stories, learn how to advocate for yourself and your loved ones, and understand the unique challenges faced by military and veteran communities. Our mission is simple: shine a light, spark change, and fight for the care and dignity our service members and their families have earned. We'll return to our regular Living Chronic content soon, but right now, if you've served or if you know someone who has, please share this series. Together, we can push for real change and make a real difference in the lives of those who've sacrificed so much. This is Brandy Schantz, and you're listening to Living Chronic. Today, we are talking about veterans. This is our special mini-series, Veterans, Medicine, and the Mission Left Behind. And once again, I'm here with Helen Perry. She is a veteran, nurse, caregiver, and all things healthcare guru, as well as a nonprofit executive. So welcome back, Helen.
Thank you.
So today we really wanted to talk about something that you and I have spent more time in our lives doing than we ever wanted to do, and that is advocating for yourself, for your loved one, for your patients if you're a nurse. How do you advocate for the person that you are caring for, often that person being yourself? So most people know my story. I obviously, being somebody with no healthcare background whatsoever, had to advocate pretty hard for myself to get a diagnosis when something was quite clearly wrong. And your husband, has benefited from your expertise as a nurse practitioner, and a military healthcare provider for advocacy when he needed it the most. So tell me a little bit about your background in advocating for yourself, your husband, your patients, and what you want to help everybody to learn today.
Yeah. So I think, first I want to say that for people out there who are listening, whether it's veterans or family members, if you are feeling like you are in a system and you are stuck and you don't know where to go and it shouldn't be this hard, yes to all of those things. I just want to like put it out there that like the systems that we work in are intentionally complicated. And it's because the more complicated these systems are, the less people who will make it through the bizarre puzzle of, resources and actually like come out on the other end. So it is kind of intentionally made this way to be this frustrating. And it's unfortunate that families get caught up in this. I can remember, I was a critical care nurse when Matt started having seizures. So my husband was blown up in Afghanistan, hit by 3 very large improvised explosive devices on the same day, actually within hours of each other. But in 2008, we didn't know what we know now about traumatic brain injuries and diffuse axonal injuries and all these, brain trauma and overpressure injuries. And so he, carried on the way that a lot of people did. And in 2014, he developed these life-altering, life-threatening seizures. So, people are probably familiar with seizures, the big shaky types. There's also lots of other subtypes of seizures, like staring spells, which are called partial focal seizures. Sometimes people call those petit mal seizures. There's also this thing called focal awareness seizures. Matt has the wonderful luxury of having all types of seizures. His brain just likes to kind of do its own thing. And when he started having seizures, he started with grand mal seizures. They were very long. They qualified as something called status epilepticus, which is a life-threatening emergency. It's basically a prolonged seizure of the brain that really risks basically burning out the brain and patients becoming brain dead because of it. And he started having these seizures, and it was just out of the blue. And I can remember, initially the doctors were like, oh, it's drugs. And I was like, that man has not used a drug in his life. Like, it is not drugs. Do a urine drug screen. And they did a 7-panel. There's different types of panels of drug screens they can do. They did a 7-panel, and it came back negative. And they said, well, it could be one of the other. And I said, no, do the 11. If you think that this is drugs, like, do it. And so they did the 11 panel, and it came back negative. They actually did a second 11 panel. It came back negative again, right? And the whole time I just kept saying, like, it's really weird because, like, he had this really bad TBI from Afghanistan. Like, do you think this could be related? And they kept saying the same thing. Oh, that's so rare. It almost never happens. It's so rare. It almost never happens. And this was a series of doctors that we had gone through, from the emergency department, all, who insisted it was drugs, all the way through, seeing neurology on the Navy base who said, that head injuries were not the cause of epilepsy. And just for anybody out there, like, head injuries actually are one of the leading, if not the leading cause of adult onset epilepsy. And so we just kept getting the runaround, oh, maybe it's a sickness, maybe it's drugs. Like, God, they kept coming back to that. And then at one point, even, because after they would start him on medication and he wasn't responding, then they started writing things in his medical notes like, wife claims to be a critical care nurse, wife claims to be giving service member his medication. And I was like, what do you mean claims? Like, you are prescribing the medication. We are giving it the way we are prescribed. Like, what do you mean? Like, it sounded so accusatory, and it kind of was. Like, they were sort of backdoor insinuating that, like, we were just, at one point a provider even made comment that, like, oh, you're just out for the VA's money. And I was like,
Oh, wow.
yeah, I was like, oh my God, like, he doesn't want to retire. Like, we don't want any of this.
Right.
And so from then on, I started, every time he would have a seizure, I would take him to the emergency department with the military, and I would make them draw his drug levels. So his anti-epileptic drug levels, we can actually test the blood to see if they're in therapeutic range, and they always were. And that was basically proving that, like, hey, like, we're not doing this. Like, you're making this accusation that we're just being difficult. And unfortunately, we're the ones having to live this nightmare of, like, not being able to control his seizures. Like, what do you want from us? And they gaslit us. I mean, are you sure he had a seizure? Do you know what a seizure looks like? Like, I'm a critical care nurse. I work, at the time I was working with patients who would have seizures in the hospital all the time. Like, yes, I knew what they look like. I can talk you through the different, like, symptomology and presentation of, like, different, focal areas of seizures, like all these things. But even for me, I was like, I got to a point where I was like, maybe I'm crazy. Maybe
Right.
maybe I'm wrong. Like, maybe I am, because they insisted just repeatedly that it couldn't be this
Helen,
bad.
that is a normal response, Helen. I felt crazy too.
Yeah.
And I realized after some time, and for everybody listening, you feel crazy, you're normal. We all feel
Yeah.
crazy. We all think it's us. After a while, we think, nope, can't be. But that's the point, isn't it?
It is. It is the point. And it's this, I think that one of the things that we have started to realize in medicine, and I say this as a medical provider now, as a nurse practitioner, I work with neuro patients. We're starting to realize through social media, through this sort of globalized world that we have now, where everybody's connected with and connected to everyone else, and we have such better access to information and experiences, we're learning that maybe some of the things that we once thought were really, really rare really aren't as rare as we thought that they were. And with the spread of medical information, patients are better informed, so they're getting more accurate diagnoses, and we have better testing and all of these kinds of things. But there is still a train of thought out there that, that patients can't possibly, know or advocate or understand these things. They're not medically trained. There's still a lot of providers out there who, for whatever reason, are really afflicted by their biases. Whether that bias is towards veterans who they think are faking, or malingering, or towards family members that they think are over-reporting, like whatever it is, providers are affected by bias, right? And everyone, regardless of how much we want to think about it or acknowledge it, like we all have bias. We try not to, but some more than others.
Right.
But we know that bias exists, and especially in healthcare. And Unfortunately with providers, one of the things that happens is, a provider will get a referral for a patient and they'll sort of read it over and they'll go, "Ugh, I know what this is." And they don't, and maybe that referral didn't have all the information. Maybe it didn't have an accurate history. Maybe it was, incomplete. And so a patient goes in to see that provider, and that provider has already made up their mind that, like, this is what it is. It's this thing. And then the patient's left being like, but, like, what about all these other things? Like, I actually kind of don't think it's this thing. I think it's something else. And so many patients end up in that position where they're left trying to convince their provider that there's something wrong when the provider has already decided that there isn't something wrong or that it's this other thing. And so it creates this turmoil. It creates this gaslighting, right, of patients who are like, there's something wrong with me. And they're like, no, there's not. And so it becomes really challenging, especially if you're not medically trained, on like, how do you advocate for yourself? How do you ask the right questions in the right way to get someone kind of out of their bias to realize that there's something wrong? And that is a hard thing to do. And it's, I went through that with Matt. Like I went through, like, first of all, I even went so far as like to call like, experts at the Defense Veterans Brain Institute, the DVBIC, and was like, am I crazy? Like, head injuries cause seizures. And I finally talked to somebody who was like, Helen, you are not crazy. Like, yes, this is like, you are correct. And here is what you need to do. And so that's kind of what I want to share with people is like, how do you, like, when you start to recognize that something's wrong and your providers are not listening to you, there's a lot, the first thing people do is they Google, right? They Google and they start researching and they start coming up with all of these, all of this list of things. And that's not a bad thing. That's called a differential. That's what we call it on the healthcare side. When, as a provider, we're interviewing a patient, we're getting all of our diagnostics together, and we're coming up with a list of possibilities of what we think it is. And so I actually think that that's a really smart thing for patients to do and for people to do, is to start researching your symptoms and researching what you think is going on to see if you can come up with terminology to be able to point your team in the right direction. Where I think people need to be really careful is where they're getting their information from. Right now, if you Google, the first thing that comes up on Google is an AI answer. And I can tell you from personal experience that AI answers from a medical perspective are frequently wrong and inaccurate. And so much so that I actually had been Googling something about partial focal seizures and looking for some other specific statistics on partial focal seizures. And the Google AI answer that came up was, children frequently have partial focal seizures, but they're of no medical concern and should not worry the patient. And I was like, screaming, like, I like reported it to Google to be like, please take this down immediately, because like partial focal seizures in a child are actually incredibly, incredibly debilitating and are very concerning. And like should immediately get neurology referral for testing and intervention and medication. It can really impair their development. So I say that so that people can be very wary of things like ChatGPT and Google AI answers or Grok or like whatever AI entity they're using, because they're not getting verified. If you want to use that as a starting point to like, what are the top 5 most diagnosed, conditions for GI or for heart conditions? If you want to use it as a starting point, that's fine. But just like with everything else, you need to use verified sources. And so, looking at things like Mayo Clinic, looking at resources like the NHS. The NHS actually has the National Health System for the UK, so it's going to be nhs.uk.gov, I think is what it is. The NHS education materials that they have out there are actually really good. And in some cases, they're a lot more informative than what like US-based education materials are for patients. So I have found them to be a very, very good, very reliable resource. You can do a lot of research through universities and institutions. And so that should give you sort of like a general starting point of like how to start. You can look at it by symptoms. And the other thing you can do for a lot of patients, they don't always know that there's like terminology to the types of symptoms that they're having.
Right.
And so that can also frequently cause struggles because they're trying to explain something to their provider and their provider is just not getting it. But if they would have used the right terminology, it just helps their provider be like, okay, like I know what you're talking about.
Or even to be more descriptive, maybe. What do you think? Because I'm thinking specifically of when I started having my issue, I kept saying, I feel like I'm in overtraining syndrome, but I can't be because rest is not helping. And every doctor looked at me and said, what is overtraining
Yeah,
syndrome?
yeah,
Which is also a good reason to introduce exercise science into
yeah.
medicine. But, um, we kept speaking past each other.
Right.
So
But if you
maybe
would have
just be
just
more
said,
specific.
if you would have said, I'm having excessive amounts of fatigue, I have elevated heart rates, but I'm not recovering with rest, right? Like then they can, sometimes it's just describing the things. Or like I had a vision thing happen. I ended up with ocular migraines, which is like a rare form of
Hmm.
migraines. But I basically had a very specific region of my vision I went blind in for like 30 minutes and it was very specific. And I was trying to discuss with another provider that afterwards I was having this visual change where everything that I was seeing was sort of dragging behind. I was like, it's weird and I don't know what to call it. And he was like, yeah, it's called trailing. And I was like, oh, I
Oh,
had no idea that that was a thing, that was like what you called it. But yeah, I guess that makes sense, right? And so sometimes if you can just do enough research into the symptoms to kind of pin down and look through the descriptions and things like that, it'll kind of help you get some of the terminology. And then sometimes that terminology can even lead you to looking up, well, you know,
right.
what causes these things? Which can then lead you to like better understanding of the diagnostic. So the thing for patients and advocates and families to know is like write down this list of differentials, right? Like I've been having this pain in my leg. I've looked up all sorts of things. I've read that it could be anything from a muscle cramp to rhabdomyolysis. And I'm concerned because, and like physically write that thing out so that you have a
Hmm.
very sort of concrete statement to give to providers. Because a lot of times these providers are like, they've got like 10 minutes.
Moving.
They're coming, they're
Yes.
going, right? They're just trying to be efficient.
Yeah, writing things down has been probably the number one thing that's helped me because if I
Yes.
don't, you get in there and it's almost like you panic and you're like, oh crap, oh crap, oh
Yeah.
crap. And they've got 10 minutes and then they're out the door. And by the time you remember everything, it's the appointment's
It's
over.
done. The other thing I would say along the lines of write everything down is keep a journal of all your
Yeah.
symptoms.
Yes.
So we started keeping, originally when Matt was having seizures, I had a seizure log. And then when he was having symptoms that I thought were seizures, but I couldn't really confirm, I started adding those kinds of events into it. So I could very specifically say, well, last week he had 7 events that I thought were seizure related, that were, not typical for for the way that he usually presents. Date it, time it, be as specific as you possibly can be. Even if you're not having symptoms in a given day, still write like had a good day, didn't have any problems. Like just keep a daily log so that you can show your providers. Because
Hmm.
the other thing is, one of the most common things that I have heard patients gaslighted with is for things like weight gain, fatigue.
Right.
When your
Yep.
symptoms are very vague, there's always a tendency for providers to be like, you're not getting enough sleep.
Yep.
Your diet is bad. You're having too much caffeine. You're not exercising enough. You're not whatever, right?
Yes.
When you have a journal where you're like, well, in the last month I averaged actually 10 hours of sleep a night because I'm exhausted and I go to bed all the time and go to bed super early. And, I have a diet log in there and, you can see what I've been eating. It's not terrible. And you can see that I've still been going out for walks and I've been doing. So when you have these these logs
Yes.
and these journal entries, it's like tangible evidence that you can give to them to say like, no, stop gaslighting me. Like I'm coming to you and telling you.
And with the technology we have today, we can do it. Now, of course, when I started having so many issues, for what at the time, it really, we're starting to know more about it today, mostly because COVID created a whole lot of people with POTS and
Right.
dysautonomias. So now doctors are a little bit more familiar with what I'm going through. But when I first started going to the doctor, they had no idea and they just thought it sounded ridiculous that this alleged runner,
Yeah.
just suddenly had a heart rate just run up to 180. But I have my Garmin watch, and of course, so many of us, you have your Garmin watch, your Apple watch. There's so many great trackers out there. I came in and I was able to bring in charts and say, okay, now let's take a look at
Yeah.
what my runs look like in January of 2020. Let's take a look at what it looked like in February 2020 when my symptoms started, and let's take a look today. And
Yeah.
they were able to look at all of this information and say, oh my God, there's something wrong.
Yeah.
Okay, so now we're getting somewhere.
Yeah, same.
But it was because I was able to bring that proof in, say, look at this.
Yeah. Yeah, and I mean even things as simple as Fitbits, they will do
Yeah.
sleep tracking at night, and it just gives
Yep.
you tangible evidence to bring to them to say, hey, look, it's not one of those things, right? Or
Yeah.
maybe, hey, like maybe you're right, maybe it is one of those things. You're right, my sleep is bad. Then I should get a sleep study, right? Like what do we do
Yes.
for, people who sleep poorly? What do we do? Maybe I need to see a dietitian. Maybe I'm not eating right. Maybe I do have food allergies. We should send me to an allergist for allergy testing. But it helps direct providers and sort of start people on the right track. The other
And that's a great point. Also, for the kind of plugging some of the great tools out there for a quick minute. In addition, MyFitnessPal app, Lose It app, I know there's a few others. If you just keep logging in everything that you eat and drink on there,
yeah,
either one, you're going to see something yourself and say, oh, I didn't realize I was always snacking at
right,
7 p.m. Or, oh, I do have 3 glasses of wine pretty often.
right,
Or when you bring that into your doctor, again, maybe the doctor will see something like, well, you know what, you're having a lot of these symptoms and it looks like you have bread and pasta a lot. Let's take a look at celiac disease.
Right.
Or maybe the doctor will say, oh, if this is what you're eating, there really is no reason you should be gaining
Right.
weight. So again,
and it
just
doesn't
kind
all
of emphasize those tools.
it
help.
doesn't have to be anything fancy. Matt's
Yeah.
seizure log, it's like sitting right in front of me. I've just been writing in it's a notebook on my desk, and I just have the dates on it. And every morning when I come in and I sit in at my desk, I jot down what his headache was, any seizure activity we had, any abnormalities that was during the day, anything unusual that stuck out, and I just keep little notes, and then I can flip back like, oh, you wanted to know how he did on November 11th of last year. Oh, he had a seizure, and I can just pull it up and reference it. So it helps you to give providers. The other thing is you can ask for those things to be scanned into your medical record. If you're going to do that, make sure that you get a copy that your provider can keep, because a lot of times if you ask them to scan it in, they'll go make a copy somewhere, but it may not necessarily actually get where it needs to be. But you can ask them to put it on your chart of like, hey, I'm concerned. I'd like to have this scanned in to my medical record to
Yeah,
show
absolutely.
the number of headaches I've been having, or whatever these symptoms have been.
If you are already registered with VA, there is now a function in My Healthy Vet where you can scan and upload
Yeah.
your personal health data. So, to
Yeah.
your point, yeah, absolutely.
Yeah, and you can also just message it to them. You can send it.
Yes.
That's been the other thing people should know about the VA is they have 3 different systems that hold outpatient records. And so depending on how you're sending documents is it may end up in different portions, and they may not know to look in the different systems to see where it goes.
Yes.
And so, so if you send it via like My Healthy Vet through like a portal message to your provider, then it's like an easy thing because you can say, hey, like I actually sent this to my PCM on this day at this time. The message was read and it had the attachment in it that included this information. And that's always a great way, especially on VA advocacy, to hold them kind of accountable is to say, no, we can see on My Healthy Vet when these messages are read and replied to.
And they can also see that on most, I know Walter Reed, the entire military health system now has MS Genesis.
Yeah.
Or MHS Genesis.
MHS,
You know what I'm
yeah.
talking about. I I was seeing my dysautonomia doctor, and I always read through the notes after each and every visit. I go in, I check, I read through MHS Genesis. And I went in, and he had some incorrect information. I mean, everybody's human, right? I mean, and there's a lot of stuff that's happened in my life and in my daily life. So, I'm kind of a complex health case over here.
Yeah.
So understandable. But I put into the message system, I said, hey, doc, there's some incorrect information here. Can you please correct my medical records to reflect the fact that this has been happening for X number of years, not what you put, and that I already had this diagnosis in 2024. And he did. He apologized. He said, oh, sorry, I made a mistake. Let me go back. But that is very important because you need to ensure that your medical records are correct and up to date. And nobody's going to do it but you. There's no nurse who's going to come in afterwards and say, hey, doc, I just read through the notes and I think you may have made a mistake. So, yeah, going back, read through the notes too and put that into that portal so that it is notated. Because when someone is reviewing your medical records, and this is, especially a big, stomp the foot moment for everybody who's currently active duty or transitioning, you want that stuff in your medical record to be correct, because otherwise you're going to start running into the people who are like, oh, but do you have this problem?
Yeah.
And now you're fighting for something that you know that you have.
Yeah.
You don't want to have to do that.
Well, and even after hospitalizations, it's the same way. When we admit patients into the hospital, I predominantly work inpatient. We do a history. We do like an HPI, the history of the presenting illness, which is like the little story at the beginning of our note. That's like, 65-year-old male brought to the emergency department after a fall with subsequent traumatic injuries to the lower extremities and loss of consciousness, right? But if you are someone who fell because they syncopized, because they were having chest pain, and that chest pain has been ongoing for weeks or whatever it is, those might be in really important details for people to know, and it may just not make it into the inpatient notes. And so you just want to make sure that you're reviewing those things to make sure that it is being documented correctly. There's a guy that I work with we sort of poke fun at sometimes because he writes these like novellas of notes. They're very extensive when he puts in, the HPI for patients. However, there have been so many times where we have needed to figure out the backstory of what happened with the patient. And the first thing we look for is one of his notes because he's so thorough. And it's honestly, being extra thorough has never hurt a patient, but being vague really has. And so, giving those extra details, and you can even ask if you're inpatient, you can ask your providers like, hey, if you could, when you write his note today or her note today, if you could include the fact that X, Y, and Z was happening, or that we've been seen for this diagnosis in the past, it would really help us in the future as we're coordinating care. And it doesn't have to be an accusatory thing. A lot of times providers they're just busy. They're trying to get things done. The other thing is a lot of them are using dictation services like Dragon Dictation or whatever service comes. And listen, the number of times that, I am saying, esophageal varices and it's writing, esophageal variants and like nobody knows what that is. And it's, so it's, you have to go through and kind of read it to make sure, because they don't always have the time to do those things. If a provider absolutely refuses to do that, the other thing you can ask is for the nurses to do it. Say, hey, you're the nurse on shift today. Would you mind writing a clinical note that we've discussed with you this history and that we think it's really pertinent to have in the medical record? And 9 times out of 10, nurses will be like, yeah, that's fine with me. Like they'll, per the patient, has concerns about XYZ, they'll write a nice clinical note that goes in there. But just so that it's in there, because you're right. That's been one of the things that we've experienced with Matt's injury is they'll get the number of seizures wrong. They'll get the types of seizures wrong. And to be honest with you, even for us, one of the things that really affected us was Matt has what's called bitemporal epilepsy, which means that he has epilepsy that comes from both sides of his brain. We actually didn't know that for like 8 years because I had not actually gone through and found the specific diagnostic report to see what it said. I knew what the provider had told me, which was that, they said it was right-sided dominant epilepsy, and it never occurred to me to say, well, was there any activity on the left? And, And
Right.
years later, we found out like, oh, no, 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 no. He doesn't just have right temporal epilepsy. He has bitemporal epilepsy, which is even more rare than, the original
Yeah.
thing that he had. Which leads me into kind of my next advocacy point is not only should you be reviewing all of your records and all of the notes that get put in, always review your diagnostic reports. So if you have imaging done, if you have lab work that's done, your lab work is not usually going to come with an interpretation, except in the case of pathology reports. So your pathology reports will come with a pathologist's designation of like what the tissue sample was. You may not always understand what those words mean, but just chop them, put them right into Google and see what Google answer gives you if you don't understand the full terminology. Because they're not always going to use terms like for pathology things like malignant or benign. Many times they will, but other times they might say it's dysplastic or mildly dysplastic or, atypical. And so you just want to make sure that you fully understand all of the words in those reports. But for your other kind of radiology reports, your MRIs, your CT scans, those X-rays, those are things where you're really going to want to read the full report that comes from the radiologist, because many times on those reports we have what's called incidental findings, and your provider may not address your nephrologist is
Yes.
not likely to talk to you about the intestinal wall thickening that you have. They might bring it up. Hey, we noticed there was some intestinal wall thickening on your last CT scan. We're gonna, we need to work with your PCM to get you referred to GI. But a lot of times they won't, because it doesn't apply to them, and it's not specific to the thing you're being treated for with them. And
Right.
a lot of times they assume that you're aware, that somebody told you, or that your PCM saw it and told you. And that is like simply not the case anymore. Just because, the way that hospitals and doctors' offices and the VA and health systems are being run, they're overworked and understaffed. And frequently these are things that get missed. And so that is why you always want to read the full report and see if there were any incidental findings in there. See if there's anything else that was seen that you need to follow up on. And a lot of times it'll tell you if it recommends other testing, if it recommends other diagnostics, if it recommends further, serial exams, like it'll tell you in there. And so you just want to make sure that you're looking at those, because, the number of times that we have had, Matt's brain scans where we looked at MRI reports and they said, oh, it's normal. And then I go and pull it up and I'm like, this is not normal. Like he had these lesions that he didn't have before, or now he has, this, which he never had before. So it's so critical for you to know what those reports are saying. Lab work is a little trickier because, blood work is one of those things where sometimes little changes are big things and other times little changes mean nothing. Other times it's very normal for people to have abnormal blood work depending on the sample and how it was collected and the time of day. Other times there's not a normal range. But generally, most of the apps that you get now will sort of tell you what normal is. It'll have like a little green zone and it'll give you the dot where your lab is. And you can just kind of scroll through and look. And the same thing applies, right? You can always Google what those things mean. If you're somebody who's been, having lots of chronic issues with fatigue and all these kinds of things, and they do a CBC, which is a complete blood count, and your white blood cell count comes back high, that's something you would want to look up to know, like, oh, that's an indication of infection. Oh, okay, maybe I have an infection somewhere, right? And then you want to follow up with your provider to say, like, hey, I noticed this thing. What does this mean something? Is this something I should be concerned about? Do we need more follow-up? And just keeping an eye on those things to know, right? And add it to your journal, right? Like on this date at this time, my labs came back weird. My MRI showed that I had, weird lesions on my brain, or, that I had, abnormal signaling in the muscle or in the tissues or whatever it was, right? You just keep that in your log so that way, when the time comes for you to advocate and to say, like, to put the big picture together, you can be like, hey, listen, I've been having these symptoms for this long, this often. I've had these abnormal tests, which were done on this date at this time at this place. And you can give them like this whole collective picture so that they're not having to, like, because that's the hardest thing in the world is a lot of these providers just don't have the time, the resources, or the
Yes.
energy to go digging through it. And so then they're like trying to help you, but they don't have everything they need. And so it sets everybody up for failure.
It makes it so much easier when you do that too. I have started doing that myself. Instead of coming in with this big giant story to tell, I do a timeline and I highlight the big important
Yeah.
points. This is when the symptoms first began. Here was my first MRI. This was my first time fainting. This was my
Yeah.
first time getting my heart rate over 180 without doing a darn thing.
Yeah.
And having that timeline and handing it over helps us get right to what we need to get to every time.
Right. And
It
then the other
really
thing
does.
is, you know, for providers who maybe don't have enough time in their appointment, it gives them time to go and look at things, you know, maybe after your appointment time has passed and they want to re-review things. You know, it creates more opportunity for communication. The other thing we would definitely say has happened to us is that we just run into outright gaslighting. You know, we run into providers, I tell them in clinical speak, because a lot of times I'll be like, hey, listen, I'm an NP. I work in neurocritical care. Like I do critical care stuff all the time. Let me just present him as a patient to you, not in patient speak, but in like provider speak. And like, let's just like cut through it, right? Some people appreciate that. Many others do not. But we have definitely had it where we've just had providers just be like, I don't think this is anything. And I'm like, really? Okay.
Well,
But there are a couple of key questions that I think people can ask that I think will help really kind of elucidate and like figure out whether this is someone, because there are definitely times where I tell patients, I'm like, find a new provider. If they are not an advocate for you, then you need to leave and you need to find somebody who is. Somebody who's going to do the work to figure out what's going on, right? Because everybody deserves that, right? And so one of the questions you could ask and the way you can phrase it, instead of just getting, you know, because I think the tendency for all of us is that we get frustrated and we get angry and then we're like, what do you mean it's not concerning that I'm throwing up blood? You know, like, right? And we hit that point because for so many people, we're dealing with this thing every day. You're tired, you're frustrated, you feel like you're just like, again, like you're crazy because this thing is happening and nobody's listening, right? And so you're already on edge going into these appointments. So one of the things you can ask is, you know, I've expressed to you that I've been having these symptoms. List out what those symptoms are. And then say, and I've heard you say that you're not concerned about it being this diagnosis because what symptoms should I be on the lookout for? What symptoms would make you concerned? And hear what they have to say, right? Because if that provider cannot verbalize to you, well, actually, really what I'm looking for is, you know, for them to have repeated marching absence spells. You know, it's very, you know, not typical for patients to only have one, you know, partial focal. Generally, they'll have multiples in a row and it sort of marches out and it repeats itself, right? If they cannot verbalize to you, like whatever it is about the symptomology that you're experiencing that is the thing that they're actually looking for to be concerned. If they say something like, oh, there's nothing for you to worry about, why do you keep asking me these questions? Or like, there's no symptoms, right? Like whatever they like, depending on how they respond, will really guide you in knowing whether that provider is worth your time to keep following up with, or whether you just need to find somebody
to move on. Yeah.
And it helps because the other thing that it can do to providers is it can kind of force them to look at their own like list of pertinent positives and pertinent negatives, which is what we call it when we're looking at these differential diagnoses. And it can help them kind of go through that list and, oh, you know, you did tell me that you were having unusual bowel patterns, and you did tell me that you were having, you know, episodes of vomiting that you thought might have been blood tinged, and you did tell me that you were having, you know, epigastric pain that was worse after eating, and you did tell me that you, right? And it can sometimes force them to kind of recount these things in a more, you know, kind of conclusive list that makes them go, you know, I tell you what, why don't we just put you in for an EGD? And we can just we can look and see if there's any abnormalities and make sure that you don't have, you know, an ulcer or, you know, whatever. And so asking them, like, what are the symptoms that you would be concerned about? What would happen? Like, what would make you be concerned? I think is an excellent question that patients can ask. Another way to phrase it is, what should I be looking for if I'm concerned about X, Y, and Z?
Yeah, that's great advice. Yeah.
Yeah, it just, and it helps people. And I think also, again, going back to that journal, when you get the answer to that question, write that information into your notes, right? Saw Dr. So-and-so on this day who said that I should be, looking for these symptoms. I have those symptoms. I don't have those symptoms, whatever it is, so that then you can kind of direct yourself. And if it does come to the point of needing to find a second opinion, absolutely patients should get a second opinion.
Absolutely.
I think,
and I think it's a good, something from the non-medical world over here that just shocked the heck out of me to learn as I've been going through this. Most healthy non-medical people think that you walk into a doctor's office, they run tests, and voila, there is an obvious diagnosis.
No.
So it took me some time, but after going to see these doctors over and over again, I quickly realized they're analysts. Mm-hmm. They're analysts. Now, what makes the healthcare system so unique, anywhere else you go, if you're speaking to a financial analyst, maybe you're talking to an intelligence analyst in the Army, maybe you're speaking with somebody who analyzes the water in your system, they're going to generally follow the same pattern, right? They're going to present the facts, whatever came from that test or their observations or what you've told them, or a series of all three of those things. They're going to put that into an analysis and then give you possible outcomes. Or if there's something definitive, like, oh, we just found a lot of mold in your house, well,
right.
Then there's the analysis. We found mold. If they just found a cancerous tumor in your body, well, they're going to say, we found a tumor, right. We need to do something, here's the steps. But for most things in healthcare, there are different possibilities and different courses of action. And what I found very interesting about healthcare is the overwhelming majority, as a matter of fact, doctors don't present it that way. They take a look at the facts, they don't really go over them with you, and they say, this is what I think, and then it's over. That's it. Well, I didn't ask, your opinion. I asked you to give me again, every other professional in the world would say, okay, so here is what we know about these facts. Here is what the majority of people think this could be. These are some other possibilities. This, and this leads me to believe it's more likely this than that.
Yeah.
However, there's always a possibility it could be A, B, and C as well. Here are our courses of action. Let's discuss and decide which one is best for you.
Yeah.
And that's how every other field in the world analyzes a piece of information and presents it to their client, their boss, whoever.
Yeah.
In healthcare, we get doctor's opinion, and it so often comes across, well, I think this, and then it's over. And of course, if any other job in the world, you'd be fired for doing something like that. But I think as patients, because we don't understand that so much of this is soft science based on hard science, and it's an analysis. So we just say, well, he said he doesn't think it's anything, so I guess I'll just go home. Instead of saying, hold on, doc, I didn't ask what you think. I asked, what are the possibilities? Now let's discuss what you found. Let's discuss what's out there, and let's discuss my potential courses of action. And then if they're still not willing to do that,
move on.
Yeah. But I think the non-medical people need to understand, so often you come in and you feel inferior or intimidated because, well, I'm not a doctor. I didn't study any kind of healthcare or any science at all, or whatever you're feeling. And when the doctor says that, you just kind of slink out with your head down and think, well, I guess I'm crazy then, or maybe he's right. Maybe I'm just eating bad, and now I feel like I'm going to die. And what you really need to do are ask the questions that you have said and push back and say, you know what? I didn't ask your opinion.
Right.
I want a professional analysis, and I would like a professional presentation, please.
Yeah. And I think there's, we see that most in emergency medicine. If you actually get, a lot of people also don't understand that there's a difference between a discharge summary and the actual notes that we're writing on patients in the hospital. We give you a discharge summary. That's just like a list of information of like, maybe it has your radiology results, maybe it has your blood work in it. your final diagnosis, but it does not include what we call the differential, so the list of possible things. Most of the notes from emergency medicine will now include a list of differentials somewhere in their note because it's a requirement for billing and reimbursement and the way the systems have it. But you don't ever see that, right? Because like,
Right.
you know, and half the time the providers don't ever talk it over with you because a lot of people don't understand that the practice of medicine, the reason that we call it that is because it is the practice of medicine. And some people are very, very good at it and other people are very, very bad at it. And,
Yes.
you know, I think that there's this assumption in medicine that everybody is in it for altruistic reasons and because they want what's best for the patients and they want, you know, they want to do good by humanity. And that is not always the case. There are
Right.
lots of people out there who work in medicine because a lot of different reasons that are not altruistic, right? Whether it's money or whether it's whatever. But to make sure that you find a provider who actually cares about helping you get to the bottom of it. And the thing is, you know, sometimes there are definitely times where I've had patients come to me and they are not right about what is going on with them. I have had some people bring me some like very like far left field where I'm like, wow, that is not what I thought you were going to tell me you thought was wrong.
Right.
But generally speaking, I will say that the vast majority of the patients that I have had come to me and tell me that something is wrong and that they've thought it was X, Y, and Z, a lot of them haven't been right or they've been close to right. And they've at least helped me as a provider get on the right page for like getting them an answer or solution or treatment. I will also say that especially for, this is especially true with neuro patients. The neuro community, and I don't know why it's like this, but we have a tendency to negate and to dismiss the observations of family. And I will say that that's true for elderly patients, especially with things like Alzheimer's and dementia. That's true for our young TBI patients, like my husband. That's true for pediatric neuro patients, that they tend to, that for whatever reason, the caregivers tend to be dismissed. And that's true, honestly, for all, caregiving situations where you have a caregiver who's really doing the majority of the work for an individual, PTSD, mental health issues, all those things. And don't let them dismiss you. I can remember I had a patient who, he had a very severe traumatic brain injury. He was not military, but he had a caregiver who was very, very involved. And she knew him better than any diagnostic could. She could tell you when he was having a bad neuro. In neuro, we talk about good days and bad days because everybody thinks it's this like upward linear progression into recovery. And the truth is it's like this spiral of like one step forward, six steps back, up, down, sideways, backwards, all these things. And she could tell you when he was going to have a bad day. They'd go in and they'd say, hey, like, we're going to do a little extra physical therapy today. And she'd be like, not a good day. He's just not into it today. Something's off. And she was right every time. Every time she would say that, we would run blood work or do additional tests. And she was right on the money.
Spot on.
And, truth be told, like, the same thing is true for, like, my husband. Like, I stare at this man every day. Every day I am with him. I can tell you when he's having more seizures. I can tell you when he is more anxious. I can tell you how he's going to respond to things because I am with him 24/7, 365 for the last, at this point, 11 years that we've been going through this after seizures. Like, I can tell you, right? And so when we run into providers who are negating what I'm telling them as a caregiver, it is a huge red flag to me because I'm like, I am an expert in this man. 10 years,
Yep.
10 years I'm standing here like, right? And similarly for patients who are not in caregiver situations, but are just dealing with their own chronic illness, like you're an expert in your own body. You know when something's wrong, right? And so finding providers who will listen to you, who will be compassionate with you, who will help advocate for you is critical. Because there are so many times where, patients will say little things that don't seem like big things to them, which to us as healthcare providers are like instant red flags, right?
Right.
And so it's critical that you have that healthcare relationship. And if you don't, find providers who will. Keep
And
fighting until
you know
somebody
what?
listens.
They're out there.
They are.
And one thing I've learned, and I feel very fortunate to have this access. I use Walter Reed frequently. I also use the VA hospital in DC frequently. Both of those hospitals are teaching hospitals. Both of those hospitals have many, many med school students in those hospitals. And I'm sure there's a lot of people listening right now who think a med student,
They
what's
will
a
spend
med
a
student
lot of
going to do
time
for
with
you?
you. Yeah.
They are the best
Yeah.
to have in the room. Why? Number one, they're trying hard because they want to be good at their job. They
Yeah.
want to learn. I have, and of course, being the complex medical case over here, I have walked into a room and seen that young medical student sitting there, and that medical student has said to me, I spent all night reading over everything, making sure I understood. I went all the
Yeah.
way back to this year and I saw this happen to you in 2006 in Afghanistan. And I'm like, wow.
Yeah.
But that stuff is so helpful.
Yeah.
And there is a big difference, I will say. Now, I can't tell you about the specifics. I don't know all of them. I have had some great guests who were very much experts on medical education, but I do know just as a patient, there's a big difference between the folks who went to medical school in 1972 and the people who went to medical
Yeah.
school in 2022. And I'm here to tell you, I have had some really great doctors who've been practicing for 40 plus years, but a lot of times I go in to see that neurologist who's been around for 40 plus years, and I feel like I'm almost always going to get dismissed.
Yeah.
It's always going to be something condescending, and hey there, little lady, I'm a neurologist, I know everything. But when I see that, guy, you walk in the room and you first think, oh my God, how old is this kid?
Yeah.
Are you old enough to be here? And then they turn around and they listen to you and they treat you with respect and they say things like, I don't know.
Yeah.
And to me, that's the most important thing you can hear. When somebody says to me, I don't know, I don't think, oh, I
Yeah.
need somebody better. I think, thank you.
Right.
Because there's so much out there we don't know.
Yeah.
There's so much. There's 10 years from now, we'll probably look back on my entire medical journey and think, oh, how terrible. Thank goodness we know exactly what that is now and know how to treat
Yeah.
it. But that's not what my experience was,
Yeah.
because there's so much we have to learn, and they understand that.
Medicine
So look for the young
changes.
people.
Medicine changes so quickly. I mean, we're learning new things constantly. And the hard thing is what, once you're out of school is you're not getting exposed to, hopefully your provider in whatever specialty goes to a conference and attends, they do their continuing medical education appropriately, and they're looking at things that are actually relevant to their practice. A lot of times though, and I don't mean this as a judgment of anyone, this is true of anyone in all fields, right? A lot of times they're not.
Yes.
A lot of times they're not. They're just doing what they have to do to get by. They're doing whatever's
Yep.
easiest. It's not necessarily the most pertinent to them. And they're just checking a box because they have a lot of other things and a lot of other responsibilities. And so when you're getting medical students, or you can also, residents and interns can sometimes be the same way. Frequently they are actually spending the time doing the research. They're involved in the research for those conditions. And so they're much more likely to be attentive to those things and less dismissive. The other thing is knowing where people fall, in the spectrum of their training and understanding their training, if you're at a teaching institution, which many hospitals are, you are going to come across students who are involved in your care. And it is absolutely up to you as a patient whether you want them to be involved or not. I think that they bring a lot to the table. But there are a lot of people who will say, I don't want a surgical resident who's in their first year to do my surgery. And it's like, okay, I can understand that. I definitely don't want the guy who's never placed a trocar before in an abdomen to, be the one figuring it out. But also understand they're not doing that alone. There's an attending
Right.
surgeon who's right next to them, who's teaching them how to do these things. And so, everybody has to learn. And, there's a reason to have nursing students involved, or, medical students involved, or interns or nurse practitioner students or whoever, to help them get those experiences. And also for you to be able to share your story of what you've been through, because I think it helps students learn about the goods and the bads of medicine.
Yeah.
I have definitely seen in my own clinical practice, patients who have been gaslit into thinking that there's absolutely nothing wrong with them. And then they do have very severe, very significant things wrong with them. And, I think that for a lot of providers, it's not intentional. I think many of them are victims of broken systems that don't allow them to spend enough time with patients to have access to the right resources to be able to give
Certainly.
people, appropriate diagnostics. And so, it's just important for patients, if you're going through that, if you're going through something with your loved one where they're not getting the care that they need, where nobody's listening to you, like it's a broken system. Like it's
It
everywhere is
is.
short staffed, everywhere is under resourced and overworked. And it's very hard for these providers, especially with difficult cases, to take on more work than they already have because
Yeah.
there's just not enough resources out there. And so I would say don't, the best way to advocate for yourself is from a calm, cool, collected point. There is the point gets made whether you're screaming at somebody versus whether you're saying, "Hey, I don't think this is sufficient care and I don't think this is in line with standard of care and I'm requesting
Hmm.
X, Y, and Z." That comes across a lot better than, people screaming or threatening or these kinds of things,
Right.
right? And so, I would just encourage people to like, I know it is so hard when you're in
It's
the
difficult.
moment to take that breath and be like,
Yeah. It's
okay,
difficult.
hold on. And you can even tell providers like, hey, I need a minute. I'm frustrated. I'm sorry that I'm coming across as, combative or, berating, but I'm frustrated. I just need a minute. I want to come back to this conversation so that I can continue to express to you and
Or just tell them up front
plan.
you're dealing with trauma. And I just recently started doing that, and I realized how helpful it is to just set the expectation up front. Hi, I've been dealing with this for 5 years. I have worked very hard to drive my own diagnosis after being told multiple times it's probably just my PTSD.
Right.
So I'm dealing with a lot of trauma. I'm very frustrated. I've lost my entire life as I once knew it. I'm trying to do my best here, but it's getting more and more difficult because I am dealing with that
Right.
trauma. And usually people, they get that. They're like,
Right.
yeah, I'd be, that is a lot of
Yeah.
trauma. Okay, I
Yeah.
get it.
Just having that acknowledgement, I think, goes a long way for people. Also, know that there are patient advocates out there.
Hmm.
If you're in a situation for whatever reason where you can't change providers or you're inpatient and there's they're not whatever is happening, especially in the VA system, they do have patient advocates. Hunt them down. Make them do their
Yes.
job. It is their job. Even if you're not in a VA hospital, most other hospitals have a patient advocacy department or some form of department that works with patient relations or whatever it may be. There's some department where you can go to be like, hey, I'm having a problem and I need your help fixing it. And
Hmm.
utilize those resources. Know that
Yep.
those resources are out there for you, and to help you, get answers to the things that you need. It is a difficult landscape for healthcare right now for everyone.
It is. It is.
And it is especially hard for patients who have chronic diseases, especially if you have rare chronic diseases, it's even harder. There are more specialists leaving the fields right now than are coming into the fields. That's true sort of
Hmm.
universally. And so it's just getting harder and harder for people to access care. And the other sort of like tidbit I just want to put out there is if you are someone, if you are a loved one or, if you're a caregiver, if you're a veteran, if whoever, and you're dealing with a chronic issue, please know and understand that the emergency department is probably the absolute worst place for you to get help and resources. And
Yes.
I mean that in the most
Yes.
loving way possible.
Yes.
If you have an emergency, a true life or death emergency, and you need to go to an ER, absolutely 100%, call 911. But if you are somebody living with a chronic condition, whether it's mental health, whether it's Crohn's disease, Alzheimer's, whatever it is, it does not matter. Have a plan with your provider on what to do in an emergency. If you have
Yes.
a flare, if you run out of medication, if you like whatever it's going to be, you need to have a plan that is not the emergency department. Because what happens is that patients who have these complex diagnoses come into the emergency department and they're sick, they're hurting, they're in crisis, they're having problems and they need intervention. And the emergency department is not staffed or prepared or knowledgeable to deal with those situations. And you get set and you get triaged. And a lot of times these
Yes.
patients will get sit in a waiting room because they're not triaging as someone who's having, what the emergency department would consider a life-threatening emergency. And a lot of people try to get away with it and they'll say, "Oh, I'm having chest pain." They think that that's like the magic words, but then they get further
Yep.
triaged and then they still get set in a chair,
Yep.
right? And so all of these things happen, and then you're waiting to see a doctor, and you get an emergency medicine, or a PA or a nurse practitioner who maybe knows absolutely nothing about your condition or your history or how
Hmm.
complex it's been. And at the best, you will get somebody who's like, "Hey, I want to try to help you get through this." At the worst, you're going to get somebody who says, "There's nothing wrong with you. You need to get out of here." And you don't get any
Yes.
resources. And you get a huge waste of time. You're fresh, like all of these things, right? So if you are somebody who has, like my husband, for example, has a severe seizure disorder, his seizures we know about. There are very specific times where we need an emergency room for very specific medications. And I have a list of like, if then. If he has more than two seizures in a row that are not treated with his rescue medications, that are past a certain time point, and we cannot get in touch with his neurologist, then we will call for emergency rescue medication, the emergency, call for paramedics to come take him to the emergency department so that he can get an infusion of, a rescue diazepam long term for treatment of status. Like we have like a very specific. We take our providers, our neurologists' contact information with us. We ask the emergency team to call that provider to have a direct conversation, specialist to specialist with them so they can know exactly like where we are as patients and what they should and should not do. We have it very, very specifically lined out. That is the kind of thing that patients need to have, because unfortunately what happens is patients have, they have, a flare, or they have complications, or they run out of medications, or, something happens. And a lot of times they'll call, a PCM, or they'll call somebody and they'll say, "Oh, just go to the emergency room." And it's like,
Right.
that doesn't help anyone. Again, if
Right.
it's an emergency, 100% go. 100%. If you are life, limb, or eyesight, please take yourself to an emergency. But if it's not, then we need to be pushing back and saying that is not appropriate. We need a case manager. We need to talk to the clinic. I need a call back from the doctor. Like, we need to know how to deal with this. And a lot of times, if you ask your providers, "Hey, I'd like to come up with an emergency plan," if especially, this is especially true for chronic pain patients,
Yes.
"Hey, I want to come up with an emergency plan of what to do if I go into crisis. If I'm, if I'm this way, what are the steps I should take at home before we look at seeking emergency care because of all of these things?" And I think that just helps set people up for success so much better than, "I'll just go to the ER. That'll be all right." And
Right.
it's like, oh, like that's the worst possible place, to go, because we just don't have the resources or the time to give patients the attention that they
Right.
need in these situations.
That's great advice. Oh, thank you. We've gone through so much today. I mean, what a great learning opportunity. There's still so much to learn. It's so hard to advocate for yourself, but having these kinds of tips and tricks do make the difference. So, I really appreciate you going over all of this and just helping us to get a little bit more insight into the healthcare industry and how we can better navigate our lives and the lives of our loved ones who are going through chronic illness, emergency, other kinds of things. So, thank you again for being on the show. I'm looking forward to our next episode. Again, we're doing a really great special series, Veterans Medicine and the Mission Left Behind. This is some great information, and I really appreciate all the work you're doing to help veterans each and every day.
Thank you so much. It's always fun to have these chats with you.
That's a wrap for this episode of Living Chronic. I hope today's conversation gave you insight, inspiration, or at least a little reassurance that you're not alone on this journey. Living with a chronic illness or disability comes with its challenges, but it also comes with strength, resilience, and a community that understands. If you enjoyed today's episode, be sure to subscribe, leave a review, and share it with someone who might need to hear it. You could follow me on Instagram at Chronically Brandy Schantz, other socials at Brandy Schantz, or my website at brandyschantz.com for more discussions, advocacy updates, and everyday strategies for thriving with a chronic illness. And if you have a topic you'd like to hear about, send me a message. I'd love to hear from you. Until next time, keep pushing forward, keep advocating for yourself, and remember, you are more than your diagnosis. You are powerful, you are unstoppable. Thanks for listening to Living Chronic. See you next time.